Hello, I'm Julie Robb with Era Living, and today's presentation is on memory loss, what is normal and what is not, with Dr. Chris Rhodes with the UW Memory and Brain Wellness Center. Before we get started, today's presentation, I would like to share just a little bit about Era Living for those of you who may not be familiar with our communities. Era Living, established in 1987, is a locally owned and family-operated collection of 8 premier residential retirement communities here in the greater Seattle area. Our communities help residents stay engaged and connected every day while covering cooking, cleaning, and care for those who need it. For over 20 years, Era Living has pioneered a powerful collaboration between retirement communities and the University of Washington School of Nursing, Pharmacy, and Social Work. Through these long-standing partnerships, residents benefit from the latest industry research, as well as innovative wellness and active aging programs. Assisted living services are available at all 8 Era Living communities, and we proudly offer secured memory care at 2 of our communities: the Gardens at Town Square in downtown Bellevue and Ida Culver House Broadview in northwest Seattle. Both of these communities utilize the Best Friends approach to providing care for our residents in their wonderfully supportive terrace memory care wings. This approach is based on the notion that what a person with dementia needs most of all is a best friend who empathizes with their situation, remains loving and positive, and is dedicated to helping the person feel safe, secure, and valued. I encourage you, when you have time, to learn more about Era Living, our unique UW partnerships, and of course, Era Living Memory Care by visiting our website, which is www.eraliving.com, or you can give us a call on the phone, 206-508-1294. All right, so now on to our main event. We are honored to host Dr. Chris Rhodes, who will be presenting on memory loss, what is normal and what is not. Dr. Chris Rhodes is a clinical neuropsychologist specializing in the evaluation and treatment of dementia and neurodegenerative disorders. He currently serves as the primary neuropsychologist for the UW Memory, Brain, and Wellness Center at Harborview, and is an associate professor in the Department of Neurology at the University of Washington School of Medicine. So with that, I'm going to go ahead and turn it over to Dr. Rhodes.
Thank you so much. Thank you for the introduction and the reminder that I need to update that. I no longer consider myself the primary neuropsychologist for memory and brain. I was, but we have expanded, and now there are many of us here. So I will, in all humility, I will say I'm not the only one here. But it is an absolute pleasure. Thank you to Era Living for the invitation to come back. I frequently comment that I must not have screwed up the previous presentations enough to not get invited back. So here we are. I'll try to maintain that streak today. And I want to thank you all also. I'm looking, I see 197 unique devices, 198 and increasing, connected to this today. And I see some of you with somebody else in the room too. So there's well over 200 people here. And that really is, I think, one of the benefits of being able to do a presentation like this via Zoom. So I really, really honored that you're taking this time out of your day to come learn a little bit more about memory loss. So let me share my screen, and then I'm going to ask Julie for a thumbs up that it is what you should be seeing. How's that look? Now I can. Okay, good. So I can see nothing else now for some reason, but we'll trust that it's all going to go okay. All right. So here's what I was hoping to talk with you about today. I'm going to take presenters' privilege of talking about a little bit more than just what's normal and what's not. But I do want to talk about that because it's one of the most common questions that we get in our clinic here, the Memory and Brain Wellness Center at Harborview and the University of Washington. I want to set the context also in terms of trends, why this is important. And I would say any of you who are living with memory loss or have a loved one or a family connection, you already know why it's important. And, I have a very personal connection to the disease of Alzheimer's disease and vascular dementia as well. I want to talk a little bit about health and healthcare disparities, very important topics. And then I want to edge into the territory of what we can do to help keep things in the more normal realm. Um, and then to talk a little bit about an update for some programs and services that are happening here in Washington State. So to give you a little bit more than just kind of what's normal, what's not. Um, all right. So, and the other thing I want to let you know too is I am happy to send a copy of these slides to Era Living. There's a lot of information in here. I am always guilty of trying to pack too much into a presentation. So I will send a PDF of this, and they have graciously offered to send it out to you. But I want to start with an acknowledgement that Alzheimer's disease and dementia, which we'll define in a little bit here, are worldwide problems. These are not just problems of the United States or Europe. As a matter of fact, the majority of cases of dementia are occurring in low and middle income countries, who are also expected to see a significant rise in those number of cases by 2050. The other thing that is striking is worldwide, this is a largely undiagnosed problem. So here in the United States, only 45% of people with dementia have a diagnosis. And in India, only 10% do. So there's lots of work to be done. And it's hard to think of about another health condition, especially one that affects people in such personal and pervasive ways, that is this undiagnosed and untreated. And some of that is stigma. Some of that is lack of knowledge, including providers who still believe that, well, what's the point of diagnosing somebody? There's nothing you can do. Um, we know that that is not true, and I hope to change that opinion if you hold it today. So lots of work to be done. Here in the United States, if we get a little bit more local, the most updated facts and figures, courtesy of the Alzheimer's Association, are that we've got about 6.5 million Americans with Alzheimer's disease. About 6.2 million of those folks are over the age of 65. There are about 300,000 or so with early onset Alzheimer's disease, meaning before age 65. We've got another 5 million with mild cognitive impairment, and about half of those cases are due to underlying Alzheimer's disease. And the other half then are due to something else. And I already saw one question in the chat about, are there reversible causes of memory loss if it's not due to Alzheimer's disease? And the answer is sometimes yes, and we'll get into that. And then there's this kind of mysterious and murky concept of subjective cognitive impairment, or SCI. And there are 15 million people over the age of 45 with this really strong sense of, boy, something is changing, and something is changing more than I would expect just as I get older. There's something going on here, but it's not detectable on our traditional tests or other measures or diagnostic procedures. And we do know that people are often very good at detecting those changes. Not always, but pretty good. We also know that age remains the greatest risk factor for something like Alzheimer's disease. And your general risk is about 11% after the age of 65. And you can see that kind of by age band, that number goes up significantly. So if you are 67, you've got about a 5% chance. If you're 87, that might be closer to 35%. And I want to be clear too that there's a difference between the disease and then the clinical syndrome that accompanies it. So you could have the disease but not have any symptoms. But this is talking about people who actually develop significant cognitive impairments. And again, less than half are diagnosed. Of those people who are diagnosed, there's also about 45% who are told of their diagnosis. And this to me is completely incomprehensible. I can't think of any other healthcare condition where you wouldn't be told that you have this particular thing, like diabetes or cancer. So there's a real discrepancy here. And what we know locally and countrywide is that the vast majority of healthcare providers and systems don't have good care pathways or clinical protocols for how to deal with this or diagnose it. And it is an all too common story of, oh my gosh, it took multiple providers and sometimes even multiple years to get a diagnosis. despite having concerns about this for a long time. It's still a very tricky process for an expensive process for a lot of folks. I also want to acknowledge that those numbers obscure some very, very important differences and disparities, and including the fact that 2/3 of all people living with dementia are women. Moreover, 2/3 of all caregivers for people with memory loss and dementia are women. So women are doubly disproportionately affected by dementia. And there may be some biological reasons for that. There may be some interactions between genetics and hormones. There may be, some of it driven by the fact that men tend to die earlier from heart disease and other health conditions. But a good chunk of it seems to be driven by disparities in education and occupational um, opportunities, especially for women of certain generations, and how that shapes health behaviors. So there's a real kind of biopsychosocial kind of model for why these differences may be so striking. Similarly, compared to Caucasian counterparts, our Black and African American older adults are twice, maybe 2.5 times as likely to develop Alzheimer's disease and dementia. Our Hispanic populations are time and a half more likely. They also tend to be diagnosed at a later stage with more severe symptoms. And we don't fully know for our tribal communities, but data coming out of the Kaiser system in California and some of the work that we're doing in conjunction with our colleagues at Washington State University would say it's probably about 2 to 1. And there are some very kind of salient drivers of that, including head injury and diabetes rates and all those things. And also really needing to be very, very aware and intentional about acknowledging the differences between tribes are sometimes greater than a tribe and a different group altogether. So there's, you can't kind of lump everybody into one particular ethnic group. If you are interested in this, here's one of those resource slides. The Alzheimer's Association put together a really lovely special report on race, ethnicity, and Alzheimer's disease and dementia for the last series of facts and figures from 2021, and a really nice discussion about the difference between health and healthcare disparities, and some steps to take for healthcare systems and providers and researchers to start to build those bridges and serve the communities that have traditionally been underserved or disproportionately affected. If we drill down more locally, for those of you who are here in Washington State, acknowledging that not everybody may be, we have a fairly stable number of 120,000 cases of Alzheimer's dementia. That's the best estimate. We still are predicting about 145,000 cases in the next few years, which that number hasn't changed, which is interesting given that the 120 has been about the same. It remains the third leading cause of death here in Washington, behind heart disease and cancer. We have the 9th highest rate in the US. We had the 3rd highest rate for a long time, years ago, but other states have done some good work around public health accounting and have done a better job of calling it Alzheimer's disease or dementia when that is the cause of death versus pneumonia or some other system failure. And we know that those numbers have had a pretty significant uptick during the pandemic. So across the country, compared to the 5 previous years' mortality rates for Alzheimer's and dementia, that number has increased about 16% over the last 2 years. And boy, doing clinical work and interacting with people living with Alzheimer's and families, the isolation, the disruption in routines, not getting other preventative health care has really taken a toll on our people living with memory loss. So it's been hard in so many ways. And it's also extraordinarily hard work for the care partner or the caregiver. So these stats are mind-boggling to me that there's roughly almost 3 to 1 unpaid caregivers for every individual living with dementia. These are often elderly spouses or adult children, sometimes neighbors, grandchildren, um, and often without any training or with their own health problems or sandwiched in between younger generations. If you were to put a dollar figure on that, it's almost a $10 billion industry, and it causes significant problems for the caregiver. It's physically demanding, it's emotionally demanding. it is often um, something that drives health problems for the person who is providing care, and then that whole system then falls apart. So I include this picture because it's these numbers that have really helped shape how we as a state are responding to Alzheimer's disease and dementia. And the question to our legislature about, boy, if 10% of this unpaid workforce could no longer do the job that they are doing, taking care of their loved one, could the state step in with resources, supports, programs, and services to pick up that slack? Absolutely not. So we need to do better. We need better programs and services. And fortunately, that is unfolding as we speak. And I'll tell you a little bit about that in a bit. But first, those are the broad overview of some of the context that drives programs, services, legislative funding, initiatives, healthcare initiatives. But to get to what is normal and what is not? And this, again, is the most frequent question that we get for people who are experiencing some very mild or early changes who come to the clinic. It's often a, boy, I am going into a room and forgetting what I went in there for. Or I run into somebody on the street, and even before masks, hard to tell who's who. It's hard to remember their name, and then I remember it, 3 hours later, in the middle of the night when I don't need it. Or, boy, I'm really struggling for words. They're right on the tip of the tongue, but I can't pull them up like I used to. Or, boy, I left the stove on the other day, and I've never done that before, or forgot to pay a bill. I had an episode when I was driving, and I couldn't really visualize where I was and where I was going. Is that normal at 75 or 80, or is that a sign of something more concerning? And the question is, the answer is to all good questions, it depends. But what we do know is that cognition changes as we get older. So our memory, our speed of processing, complex attention, flexible thinking, these are all things that start to change normally in our fifth, sixth decade, some of them a little earlier. So we know cognition tends to plateau for many things around late 20s. And there are several things that stay right where they are for a very long time, but other things start to decline. And that's the kind of the representation here by this green curve. And around age 65 is when some of those changes become notable. And these are exactly what I just described in terms of going into a room, forgetting what I went in there for. It's hard to keep up with the pace of conversation sometimes, or I can't retrieve that information right when I need it. That then kind of continues, and then there's another set of changes that seem to occur around mid 80s. But what I would say to you is that these are not changes that impact day-to-day function. They do not frequently or regularly disrupt your ability to pay your bills or remember your medications or drive in familiar locations. It may take longer. It may take more effort and more work. You may make mistakes, have lapses here and there, but it's not a set of changes that really impacts functional abilities. So that's normal aging. And if we look a little bit more objectively about some of these things, this is a graph of different cognitive abilities over the lifespan, starting at about age 25 up to early 80s. And the things that you'll notice that are declining the most, dropping from left to right, are things like perceptual speed. So how quickly I can process information, visual motor processing speed, how quickly I can encode and work with auditory information. So that from about 25 to 75 drops pretty significantly, as does some of our reasoning abilities and flexible kind of thinking abilities, spatial orientation changes. But then there are these other things that don't change. Things like our verbal ability or numeric ability. So something like being able to calculate the tip on a check, that doesn't change very much. And some of these things also actually get better over time. So things like vocabulary actually improve from 20 to 50, and with not much of a change from 50 to 80. And that's an interesting thing because it's a good index of overall abilities or crystallized intelligence. And then, of course, there are the things that we don't measure, like wisdom or kind of your role in the family or your community. So the other things that are, I would say, equally, if not more important, uh, are harder to measure and harder to detect changes over time. But that is kind of normal aging. So there's this gradual, significant for some things, and not so significant for other things. One of the things that also does not change as we get older is procedural memory or our habit memory. Things like how to play golf or tie your shoes. Um, so those things remain pretty resilient. They also remain pretty resilient even in the face of short-term memory changes in mild cognitive impairment or something like Alzheimer's disease. Long-term memory, information, semantic knowledge, facts, personal events from way back when. These are things that are pretty welded in there and are resistant to change as we get older. And also often very perplexing in terms of how could I remember something that happened in 1973, but I have a hard time remembering what I had for dinner last night. That doesn't, on the face of it, doesn't seem to make a lot of sense. But when you think about how long-term memory is consolidated and distributed in the brain, it does make a lot of sense. And then these other things like our kind of complex attention abilities, executive skills, there are some more changes. So that's a kind of a rough overview of what's normal. Again, 65 is about the magic age where these things become apparent. And 65 is also the magic age at which this other process starts to become more apparent. So for that 6.5 million Americans and with dementia and 2.5 million with mild cognitive impairment due to Alzheimer's disease, there is a different process unfolding. And this is the gradual accumulation of plaques and tangles if we're talking about Alzheimer's disease, or alpha-synuclein and Lewy bodies if we're talking about dementia with Lewy bodies or Parkinson's dementia, uh, where these are beginning in midlife and starting to gradually act abnormally and affect the function, then ultimately the structure of the cells around them. It is a microscopic process, not something that you could see with the naked eye or on an MRI always, especially in the very early stages. And it leads to a very different trajectory in cognitive function. And what you see here is this kind of deviation from the normal curve where you can have no symptoms. So you can think of this as I've got the disease itself, the plaques and the tangles, the neuropathological hallmarks of something like Alzheimer's disease, but it hasn't affected the way I'm functioning. You could have mild symptoms, mild memory loss or language changes, or you could have significant or maybe more severe changes in thinking abilities. So it's a continuum. And again, a very long process typically. The question in the chat earlier, and I'm realizing there are others that have been populating here. Let me take a quick look. I'm getting a little bit of background noise from somebody who is unmuted. If our wonderful host could maybe. Oh, there we go. So the question of are there reversible causes of memory change? And whenever we are thinking about an abnormal kind of something beyond normal aging, these are the very first things that we think about because these are typically treatable, or if not fully treatable, arrestable. So it's not a continued decline. So absolutely number one, hearing and vision loss. So sensory components to our cognitive function. Metabolic problems. This is typically why primary and other specialty care providers will do a series of labs to look at things like thyroid or vitamin B12 levels. We often see folks who are on a lot of different medications, and there are side effects for some of those, some more than others. And these include over-the-counter things. We see a lot of folks who are taking things like Benadryl or Tylenol PM, and they have things in them that are not good for your memory, some anticholinergic side effects. So doing a careful review of medications and supplements. More acute changes in cognitive functioning due to infection, folks who have urinary tract infections or other systemic infections, organ failure. So this can often masquerade as a dementia, although the onset's usually much more rapid. We also see a significant number of people who have undiagnosed and untreated sleep apnea or other sleep disorders, where sleep is fragmented or you're getting hypoxic So a sleep study can usually diagnose those. And then with treatment, people notice memory improves, not always, but often. We see, particularly during the pandemic, a lot of people who are overusing substances, alcohol, marijuana, other drugs, untreated depression, anxiety, other medical conditions, seizure disorders, hydrocephalus, things that are a little rarer, but the things you always think about and make sure you're ruling out before you start thinking about, okay, could this be something neurodegenerative like Alzheimer's disease or another dementia? So that's kind of part one. And this to me is really the importance of an early and accurate diagnosis, because that involves assessment of all these things. Let's see, what else do we have here? Also, kind of more for reference, but the concept of mild cognitive impairment, I guess I would frame it up as it's the gray area between normal aging and dementia. So there are cognitive changes that are more than we would expect for normal aging, and those are measurable and detectable on standardized testing that we do, or by report to some degree. And it's important to note, as I mentioned earlier, of that 5 million people with MCI or mild cognitive impairment, not all of them have something like Alzheimer's disease that's going to get worse or runs the risk of getting significantly worse over time. And about 10% of people with mild cognitive impairment, maybe upwards of 20%, revert back to normal aging a year later. And these are typically folks with those conditions that we just talked about on the previous slide, where that gets assessed, diagnosed, and treated, and things improve. If you have memory problems, so more amnestic MCI or AMCI, about 10% of people per year progress on where symptoms get worse to the point that they impact function and you now meet criteria for dementia. If you've got multiple domain MCI, meaning memory and something else, particularly if that something else is executive functioning, that number might be closer to 18%. So this also becomes a very important kind of window and opportunity for prognosis about what might we expect and what can you do to minimize the likelihood of that 10% or 18%. As we develop things like blood biomarker assays for amyloid beta or tau, these things are going to become important when we start thinking about disease modifying treatments and who is eligible for them and who is not. So this rubric or schematic over here on the right is more of a kind of a decision tree in a way of, is this MCI? Is it due to Alzheimer's? Do we have evidence that it is Alzheimer's? And then what does that mean about treatment? And of course, people with MCI go on to develop other things. So people with executive and visuospatial problems sometimes go on to develop Lewy body disease. People with attention or processing speed problems, it's more vascular. So we have ways to kind of quantify and qualify what these are. So again, MCI, think of it as a transition stage for many people, but that gray area between normal aging and dementia. And for all of its scariness and stigma, the word dementia really means something that you have acquired. So you weren't born with it, it's not congenital or developmental, but this acquired difficulty in at least one area of thinking or cognitive function. Could be memory, could be executive functioning, could be language. And it impacts your ability to live independently or function independently. So, and it's not due to something else like a medical problem or delirium or alcohol or marijuana or severe depression. So I think of this, you can kind of think of it this way. So MCI, somebody that would maybe meet criteria for MCI would be a, boy, I have a hard time remembering my medications, but I've got a Mediset and a little reminder system on my phone, and I'm accurate 95% of the time. Or I do have a little bit of a hard time with orientation and getting from place to place, but I use my GPS, I do just fine. With dementia, it's the GPS, the Mediset, all the scaffolding and the supports aren't really working anymore. Another reference slide. So when we think about the main things that cause dementia, and there's a lot of information on here, but again, this is more for your reference later. There are 4 primary things, and Alzheimer's disease is the most common. So again, dementia is this umbrella term. Alzheimer's is the most frequent thing that causes it. about 66 to 70% of all dementias are either Alzheimer's disease or primarily Alzheimer's disease. Vascular dementia is the next most common, about 20% or so. And that would be not just strokes, but microvascular changes that occur and kind of creep on slowly. So very like small blockages or leakages in different blood vessels. Dementia with Lewy bodies is the next most or the third most common. The second most common neurodegenerative, meaning it's going to get worse over time. And then frontotemporal dementia is the fourth and least of these, but it's very common, more common for early onset, meaning people in their 40s or 50s, especially men, but not just men, um, FTD, and they present differently. So Alzheimer's disease typically presents with short-term memory difficulties, maybe some difficulty with word finding and spatial orientation, whereas dementia with Lewy bodies typically presents with more difficulties with executive functioning or attention or spatial skills. Frontotemporal dementia can present with behavioral changes or language changes. And the reason that this occurs is different architecture in the brain is being affected by different etiologies or different causes. So that's kind of what all these associated factors. And then on top of that, you have just differences in the ways that they present. So one of the hallmarks, not always present, but very often present in dementia with Lewy bodies are both fluctuations, where somebody seems like they're doing pretty well. And then either within the course of the day or maybe across days, they're very confused and have much more prominent difficulties. They also have some Parkinsonian-like symptoms and often visual hallucinations of people or animals, whereas those things aren't present in Alzheimer's disease. People may have better days than others, but there aren't those wide swings. And early on in the course of things, there typically aren't hallucinations. So when you put together the early symptoms, how this started, what's happening over time, and all the rest of the diagnostics, that's where we can be pretty sure, aha, this is likely what this is. All right. If you are interested in more detailed investigation of each of these and description of each of these, we have some publicly available videos from our Project Echo series, and the links are here. Again, I'm happy to send these out. Um, and let's see here. Aha. The other thing I wanted to impart is that, again, there's the silent phase, kind of a mild phase, and then the dementia phase of something like Alzheimer's disease, is that this tends to be a very long disease process. So you could be in the pre-symptomatic phase where I've got the plaques and the tangles occurring in the brain, but they are not yet yielding any symptoms. You could be in that phase for 10, 15 years. You could have mild symptoms for another 5 to 7 years. And then you could have dementia for another 5 to 8 to 10 years. So this could be a 20, 30-year disease. And that is one of the hardest questions to answer when somebody gets diagnosed either with MCI that we know is due to Alzheimer's disease or dementia that we know is due to Alzheimer's disease. What is my life going to be like in a year, 2 years? How long before I can't function independently anymore? Nobody can tell you that exactly, but things like how old you are when you're diagnosed, the kind of symptoms that you have, your other health conditions, and most importantly, what you do from that point forward are huge predictors of what the next year looks like, the next 2 years look like. And often, with kind of doing the full court press of all the right things, there isn't a lot of change year to year to year. Which gets us into the territory of treatment and the belief that, boy, once, if you have Alzheimer's disease, there's nothing you can do, or, there's no real solid evidence for any things that are helpful. That is not true. It is true that there is no cure for Alzheimer's disease. It is true that there is no vaccine at this point for Alzheimer's disease. And I would also argue that at the current time, despite announcements and news otherwise, there are no readily available, safe disease modifying treatments available yet for Alzheimer's disease. But the things that you're seeing with the monoclonal antibodies, including some news releases, today, yesterday, are promising, and they're steps in the right direction, but we're not quite there yet. But that doesn't mean there's nothing we can do. And what we do know is that doing the things that we know we have good evidence around does not get rid of Alzheimer's disease. It doesn't stop the production of plaques and tangles. It may slow that production down, or it may help you kind of lean into the disease and continue to function well despite a disease process that's still unfolding or ongoing. So if we can decrease that neuropathology, it's still there, it's still increasing a little bit, but it's not what it looked like before. That keeps people in the MCI early stage much more likely. And no guarantees about that, but the data would suggest that that's exactly what happens. In the earlier upstream that you do that, the more likely that is to be true. So I want to take you through a couple of those things. And if you survey the literature, which we do pretty regularly around what works, what helps, again, not a cure, not getting rid of Alzheimer's disease, but this is the state of the art kind of multimodal package, right? So making sure that we are taking care of our hearts. Heart health is brain health, absolutely. So heart disease, high blood pressure, cholesterol, all those things are critically important for brain health. Staying active, physically active, socially active, getting great data around cardiovascular exercise, making sure if you do have something like sleep apnea, it is treated or optimally treated, or any other sleep disorders. Alcohol use, moderate to minimal. Other things like implementing some cognitive rehabilitation strategies and keeping our brains active. There's some good data around diets, the importance of managing stress, and so important to stay engaged in our communities. And that's one of the things that happens all too often is with the diagnosis of dementia, people isolate, they withdraw, they have a hard time engaging in their communities. And boy, that's something that we would love to move the needle on, is to make our communities more dementia friendly. And there is some work underway for that. So I'm going to run through just a couple of those things. Including the idea of prevention. And historically, we haven't paid a lot of attention to prevention of dementia, but the first round of the Lancet Commission findings back in 2017 uh, presented some lovely data that about 35% of all dementias are preventable. And that has been updated a couple of years ago, now with 40% potentially modifiable or preventable. And it's a lifespan intervention. So improving educational opportunities for children would eliminate potentially 7% of all dementias. Through better educational opportunities, are more cortical and cognitive reserve, as well as better healthcare literacy and occupational opportunities. In midlife, so 50s or so, addressing hearing loss would eliminate about 8% of all dementias. Traumatic brain injury accounting for about 3%. And then in late life, if you put together depression and social isolation, there's another 8%. Of course, smoking is a huge risk factor, but all of these things combine to potentially modifiable risk of 40% of all cases, which is more than the risk ratio for something like ApoE4 status for single allele, maybe not double. And if we go through just a couple of these, so exercise and physical activity. The World Health Organization put together a lovely set of guidelines in 2019, and it has some of the best data. It was moderate quality evidence and a strong recommendation that if you are an older adult without MCI, it is highly recommended to keep your brain in that normal cognition category to reduce the risk of cognitive decline. If you have MCI, there is modest evidence, not spectacular, but those studies, the ones that are the most compelling, were done after this was completed, that exercise, if you have MCI, may reduce your risk for progression to dementia. And then there's less good evidence of, if you have mild dementia, does it prevent you from developing moderate or severe? Those studies are a little harder to do. And the amounts are here. So it's about 20 to 30 minutes, 5 times a week, moderate intensity, or 75 minutes, vigorous intensity. So more like 80% of your maximum heart rate. They also talk about, if you have mobility problems, you should be doing balance and fall prevention exercises, reduce risk for falls and cognitive impairment that comes from falls. If you can't do that because of musculoskeletal or orthopedic problems, work with your providers, a physical therapist to do as much as you can. Something's better than nothing. One of the compelling studies that came out around that time was this really nice kind of randomized control trial of people with Alzheimer's disease and looking at amyloid beta levels in spinal fluid. And what they found, so over here on the left in the group A, in gray, these are people with not a lot of amyloid beta. So they've got some, but it's not a ton. Their cognition didn't change much from baseline to 8 years later. But those with a lot of amyloid beta, there was a significant decline on this cognitive composite, although not for the group who exercised. So doing that level of exercise is outlined by the World Health Organization guidelines, not much of a change. And if anything, not any different than the low amyloid beta group. And more cortical thickness in some of the key regions like the insula, the inferior temporal gyrus, the precuneus, where we know Alzheimer's disease tends to manifest first. And this is one of many, many studies. There were 80 meta-analyses over the last 5 years looking at cardiovascular exercise and Alzheimer's disease, Alzheimer's dementia. If you were going to do one thing, the highest return on investment, it would be exercise, which nobody loves to hear, but it is the case. How do you do it? That's always a question. I don't know about you, but for me, it's one of those things that it has to be scheduled. It's not something I'm going to get around to today at some point. You got to put it in your calendar. And the more accountable you are, the more likely you are to do it, which are why classes are so great. Interesting too, that exercise done in a group has a larger treatment effect than exercise done individually. There's a treatment effect for both, but there's extra bonus if you do it in a group. So a partner, a walking partner, physical therapist, good or trainer if you can afford one. I'm a big fan of exercise diaries. If I know I'm being kept track of, I'm more likely to do it. Kind of same thing happens with Fitbits or exercise trackers that, there's some really nice studies that show how people, once they start wearing them, are more likely to use the stairs than the elevator because, you're being monitored. The other things that predict whether or not people maintain an exercise program is if it's variable, right? So the idea that, well, I'll dust the treadmill off and I'll get on there 20 minutes a day, boring, very, very hard to do that, hard to maintain that. But if you're going for a walk a couple of days a week, you're doing a Zumba class 1 day a week, you're swimming 2 days a week, whatever it is, that kind of variability and engagement makes it more likely that people will do it and avoid repetitive kind of stress injuries. The same is true for exercise for the brain. So that's another common question of, should I be doing crossword puzzles or Sudoku or jigsaw puzzles? And if you look at that same article from the Lancet group, if you're not used to looking at these, this line in the middle, so these are randomized trials of exercise or cognitive activity, cognitive exercises versus listening to music or maybe a lecture or something like that. And if there was no difference between the two, the results, the little dots would be right here on the 0 line. If the dots are over on the right of that, that means there's a treatment effect that favors the intervention. And if it's over here, it would mean that the intervention actually made things worse. And what you see is kind of the same thing of the earlier upstream. So older adults without any cognitive impairment, there's a little bit more of a treatment effect than MCI than there is for dementia. The challenge with this is they called cognitive training many different things cognitive training. So it's a little bit of a heterogeneous intervention. But yes, there is some evidence that, if we do things that keep our brains engaged, especially if they're at the right level of difficulty, if they gradually kind of become more difficult over time, that's good. If they challenge a variety of cognitive abilities, that's good. Anything that involves new learning, card games, instruments, languages, lecture series like this, here you are doing it, great example. And the prepackaged things like Brain HQ, Lumosity, I think the bottom line for those is, they might do something. Besides costing $10 a month or so, there's no real harm to them. And sometimes they're a nice way to get started on getting your brain active if you are cognitively retired, but they're not there's nothing magical about them, I guess I would say. How to come up with this? Boy, if you have access to a speech and language therapist or cognitive rehabilitation specialist or occupational therapist, they are great. Even psychotherapists that work with attention deficit disorder and some other things can be helpful. If you have MCI or early dementia, it's super to have your care partner or someone, doesn't have to be a spouse or your direct family member, who can help with these kinds of things. Um, and I guess we could go through similar evidence around sleep and diet and all those things, but I chose those two because they're the things that people ask about most, and there are things that you can do. Um, what I would want to impart to you too is that the more of these things that we do, seemingly the better outcome or the greater the risk attenuation. So there are two very, very large prospective cohort studies out of the Chicago area that looked at people who did a combination of proactive health behavior kind of things, like a healthy diet, physical activity, like we talked about, keeping alcohol minimal to moderate. That should be no smoking, not smoking, and then keeping their brains active. Those who were doing 4 or 5 of those things had a 60% lower risk of developing Alzheimer's dementia. Might still have the disease, but not necessarily the clinical syndrome. If you do 2 or 3, it's a 40% lower risk. And these are, again, huge population studies followed over years and years and years. And the take home is, that if we do these things, the sooner we do them, the more of them we do, the greater the benefit. The other thing that is, I hinted at earlier, that is so critically important is the staying engaged and connected and getting the support and resources that you need. Support groups are great. Educational events like this are great, I think, I hope. The dementia-friendly community work. Could you imagine a grocery store where the cashier is fluent in dementia and could help somebody who is struggling with getting their credit card out of their wallet, or the checkout interface, somebody who could help somebody through that. Um, what a different experience that would be. Or first responders, or law enforcement, or those folks being more dementia aware and dementia capable. Here in Seattle and other parts of Washington, there is a phenomenal movement, the Momentia movement, that do the zoo and garden walks, Alzheimer's cafes, arts engagement events, the Dementia Friends. There's intergenerational programs. A lot of these did rotate to virtual, but are picking back up as in person. Here are a couple of my favorite photos from some of these. We enjoy a really fantastic partnership with the Fry Art Museum that has a lovely, very, very lovely arts engagement Here Now program for people living with memory loss and dementia, and a care partner. And it really has nothing to do with that other than the participants have memory loss or dementia and a care partner. And they go look at art. There's a whole strategy for, what do you think the artist was trying to convey here? What do you notice? Then they go make art. And it's some great, great stuff. Here at the University of Washington Memory and Brain Wellness Center, I see some people who know us well, either other community partners or other folks. We do a variety of educational and other programs. That's our website, virtual, in person, lots going on. I would also take this opportunity to tell you about the fairly newly launched Memory Hub. So it's our outreach center in partnership with the Fry, right next door to the Fry, here on First Hill, a couple of blocks away from Harborview. And we do a lot of things there. If you're not aware of it, there's the website, some great stuff. I also wanted to give you a very brief update on our state plan. So I mentioned earlier that those 297,000 caregivers and the 120,000 people living with dementia have been such a strong impetus for us to tackle this problem more proactively. This is work that began almost 10 years ago and has culminated in a state plan. a implementation group, the Dementia Action Collaborative, over almost $2 million in state funding right now for dementia-related programs and services. And we are now undertaking a revision of that state plan with eye towards the future, the next 5 years. There's a lot. Here's the website. Here, the kind of main point of access. If you're not familiar with the roadmap, that would be the showpiece, I think, of what we have come up with. It is a spectacular, all the way from wondering and worried to MCI, early, mid, late stage dementia. What are the things we should be thinking about? What are the resources in Washington and my community to help with that? There's a legal planning toolkit that takes some of the threat and mystery out of advanced directives and post forms and all those things. Safety, um, home and transportation safety, handouts. So there's really been a tremendous amount. And the thing that is so touching about this is all volunteer. These are stakeholders, not just people in public policy or in healthcare or research, but people living with dementia, care partners, really a very special collaborative, putting out lots of great resources. So something to know about if you don't already. One of the funded projects that I have the privilege of directing, co-directing with my fantastic colleague, Dr. Nancy Eisenberg over at Swedish, is Project Echo Dementia. And I think all I will tell you about this is it's a kind of a telementoring project where a group of us, typically here at the University of Washington, but also at Swedish and Overlake, serve as kind of a hub or an expert team for spoke sites out in the communities around Washington. So these are our sites. They are sometimes a primary care provider who is just out in a solo practice, or a healthcare system. And the goal is to increase expertise in communities where people need to receive care. So anybody who's tried to come to Harborview and park here, it's not the most fun you could have with your day. And ideally, you could get a really amazing workup, diagnosis, and treatment from the provider who knows you best, your primary care provider. So that's what we're working on. And then with a real clear who needs to come see us at a tertiary referral center. We launched in the middle of the worst part of the pandemic in June 2020. We've got about 120 providers at this point and about 47 sites from around the state. And the goal of all these things, whether it's kind of an understanding of what's normal, what's not, or what are some things that I could do to reduce my risk, or how do we improve the workforce for dementia care, is to have more people that can say this, that, yeah, I wouldn't have chosen this. I would not ever have chosen Alzheimer's disease or dementia as the thing that I want to tackle when I am in my golden years or even younger, but I have a good life. And yes, I need to make accommodations. Yes, it's not easy, but I do the best I can, and you live pretty well. The idea of living well with dementia is still kind of radical, but boy, there's a lot more of these stories and a lot more work to be done. Resources, here's links to a lot of the stuff that I've talked about. I cannot take credit for all of this at all. I've got a embarrassingly rich and diverse team here. Really wonderful, wonderful place to be. So these are colleagues. I'll skip over this one, but I also want to acknowledge that it really is a pleasure to do this in partnership with Era Living. We've got a lot of great community partners, and there's a really lovely series by Era Living that's, well, I don't know how many years it's going into now, but always look forward to this. There's our website. I will thank you for your attention. I'm going to leave this up. So this is my contact information. I'm seeing there's a bunch of stuff in the chat. So I'll leave this up as I maybe tackle a couple of these. Two things about this. One is that phone number is my office phone number where I am standing right now. That is my UW email address. That is my office. If you can see my pointer, I'm standing right there. I'm not too far away from the helipad. I am also fond of this photo because it's a reminder to me that I don't work in the ivory tower of the University of Washington. I work in the brick tower of Harborview. And if you've ever been here, it is quite the place. So let me take a look. I'll leave that up and let me take a look at what's in the chat and see what I can address here. So we talked, I think, a little bit about over-the-counter medications that are helpful. My quick answer to that would be no. If you have a B12 deficit or something like that, addressing that, absolutely. But all the supplements and things that are marketed to separate you from your hard-earned money do not have any excellent data in the well-done studies by people that do not have a vested interest in that product. But again, if you've got a deficit in something, treating that's important. We talked a little bit about is memory loss reversible, right? So things like thyroid dysfunction or sleep apnea, alcohol overuse. I see some yes pleases. I'm not sure, but hopefully that got answered. Perceived loopiness is intense. Yes, indeed, as is real loopiness. Um, let's see. You talk about Alzheimer's or dementia that's not due to Alzheimer's, right? A little bit of that. If you have more questions, that is my name. Effects of stroke on dementia. Very, very good question. Excellent question. So when we think about vascular dementia, well, two things here. One is that you absolutely can have cognitive changes after a stroke. Sometimes often those improve, maybe not always back to baseline. It depends on where the stroke is, what kind of stroke it is, whether you've had other strokes, other healthcare conditions, how you respond to rehab and treatment. So there's that. One stroke, multiple strokes are two of the 7 most common forms of vascular dementia. If you have Alzheimer's disease or another dementia, Lewy body, then have a stroke, that also complicates and compounds things. One of the things that I did not mention is the fact that mixed dementia, multiple things, so Alzheimer's and vascular, Alzheimer's and Lewy body, Alzheimer's and vascular and Lewy body, is the most common form of dementia. So most people have multiple things going on. It gets tricky when you start to try to figure out which is the primary. And if you do have a small stroke somewhere, is that contributing or is it just kind of incidental? So that gets tricky. Let's see. Certainly, there's also one of the related constructs here are TIAs, or transient ischemic attacks, and risk for stroke and cognitive impairment related to stroke goes up after TIAs. So hence the importance of getting that checked out if you are having TIAs or something like them. See some questions about slides, which again, I'm happy to send to Era Living. You've got my email address here too. I'm happy to send it to you directly. Although now that I see there was over 200 of you, maybe I'm thinking I shouldn't have given you my email address, but I think it'll be okay. Are there similar centers in the Bay Area? Excellent, excellent question. So UCSF, we are in large part modeled off the Memory and Aging Center at UCSF. They are a wonderful organization, both in terms of research and clinical services. So yes, that would be my recommendation. Slide deck, yes. Put up the slide with the contact list. I think that's still up. How do I use the link to watch the program? No idea, but I'm sure our wonderful hosts will tell you about that. Oh, what about the effects of long COVID dementia issues? Good question. And I don't think we have the data yet to be able to fully and confidently comment on that. What I will tell you is that there are multiple multi-site trials and studies right now looking at that very question. And we are part of one that's being led by the University of Texas system, looking at a couple things. One is, does COVID with neurological symptoms raise risk for dementia later in life? Or do those cognitive symptoms that come with long COVID sometimes affect the same pathways and processes as something like Alzheimer's disease or other dementias? So that data is rapidly being accumulated, but we don't know. People with dementia, I can tell you anecdotally that people with dementia who get COVID also have a range of, sometimes they've got extra cognitive symptoms, sometimes they don't. And sometimes those cognitive symptoms get better after they recover, and occasionally they don't. The bigger issue that I have consistently noticed is that disruption of routines, interactions, people that aren't going to church and socializing or aren't going to the gym to exercise. Yeah. Does weight training help? Fantastic question. Yes. And the data would say that it helps maybe for a couple of reasons. One, I think, is better understood than the other. Weight training certainly helps in terms of maintaining mobility, decreasing fall risk, all that good stuff. But there may be something, especially about kind of interspersing weight training with cardiovascular exercise, that may have some benefits in terms of brain health and plaques and tangles. Um, Kind of depends on which study you look at. It's not as consistently demonstrated as cardio. And when you think about the mechanism of action, with cardiovascular exercise, you are doubling the amount of fuel that is going to the brain typically. So you're perfusing and bathing the brain with blood, which brings all sorts of things that the brain needs to function. Down regulates things like cortisol and other stress hormones, up regulates brain derived neurotrophic factor. You get angiogenesis, vasculogenesis, neurogenesis, all that good stuff. Let's see, what else do we have? Upload this video to the Era Living YouTube channel. There you go. Have any thoughts, comments about the L-Syrian diet? My that's a good question. And we didn't talk about diet here much. My takeaway after reviewing literature around diet studies is that they are incredibly hard to do, and they're incredibly hard to do well. And what I think, there's a nice review. I can't remember the name of the journal right now. It's in another set of presentations that looked at the potentially active ingredients of how diets might help with Alzheimer's disease or other dementias. And I think what you're going to find is that we need to know a little bit more about genotype and phenotype. So for whom is something like the paleo diet maybe the best option, or the keto diet, or the mind diet, or the Mediterranean diet, or the DASH diet, or this L-serine. Yeah, I don't know. Um, but it's hard work to do. Let's see here. Say more about Parkinson's disease and dementia. Sure. So not everybody with Parkinson's develops cognitive impairment. A good number, I think upwards of about 60%, do. It sometimes remains in the MCI or the mild phase. Other times people develop Parkinson's dementia. And it is very closely related to Lewy body dementia and the presence of abnormal alpha-synuclein deposits. They might be distributed differently in Parkinson's disease dementia and Lewy body. But typically we think about, if you get the motor symptoms first and then cognitive impairment, that's more Parkinson's disease dementia. If you get the cognitive symptoms first and then some of the motor changes, that's probably more Lewy body, but they overlap significantly. And they affect different regions of the brain. So places that Alzheimer's disease typically doesn't touch, or doesn't touch until much later in the course of the disease. Um, and with Parkinson's dementia, it's more trouble with executive functioning and memory, but a different kind of way in terms of memory. But things like complex attention, reasoning, flexible thinking, speed of processing, those executive things, frontal kind of subcortical versus limbic or mesial temporal, more like Alzheimer's disease. Do they have training for spouses? I'm going to guess that might have been referring to maybe some of the programs and services like Momentia and dementia-friendly communities. If that is the case, and Ellen, you may want to clarify that, but yeah, there's there's some great, and we have wonderful kind of like Strength for the Journey or powerful tools for caregivers. Teepa Snow's got some great stuff. There's lots of spouse care partner. The excellent information, link to the slides, a lot of those. Um, does cancer treatment accelerate or cause memory loss or dementia? Excellent question. So maybe. So chemotherapy has a series of pretty well understood cognitive side effects for a good number of people, for many, many people, that tend to be kind of short-lived. The kind of the chemo brain phenomena, where once chemotherapy is over, cognitive functioning kind of returns back to baseline. there is not a lot of good data that it unmasks or opens the door for dementia. Whole brain radiation may be a little different story. So it depends, right? If you're getting uh, focal like gamma knife versus whole brain would depend on the type of radiation, the frequency, the dose, the intensity, all those things. I'm turning 90. What are the mental issues for older persons in their older decades? That's a darn good question. You know, uh, Typically, people in their 9th or 10th decades notice very much the same kinds of things that I mentioned earlier around speed of processing, where, boy, I can do all the things I need to do, but they take a long time. There isn't a lot of data that would say, cognition at 90 looks tremendously different than cognition at 85 or 80. And there's actually some data that would say if you are past 85, your risk for Alzheimer's dementia may go down a little bit. You might still get the disease, but again, the clinically significant symptoms might be a different story. The other thing that I hear regularly is just kind of the sheer ageism and boy, hard to stay connected sometimes. And whether that's um, we don't always have of age-friendly healthcare systems or businesses or technology or other things. So I'd almost worry more about that. Helpful information. I think we might have. Uh-huh. I think, unless there's any other questions, I'm also want to respect the fact that we're 10 minutes past the fact, and my gosh, there's still 180 of you here. That's impressive.
Again, if any of you have additional questions after the presentation, you can go ahead and email them to us, and we can get them to Dr. Rhodes.
Well, I will just say, last thing I will say is, again, let me stop sharing here. I really, I hope something in here was helpful, and it really is an honor and a privilege, and not one that I take lightly in terms of getting to share some things with you. You've got a lot of options how to spend your time, and it means a lot that you would choose it for this. So
Thank you very much. So I want to thank, on behalf of Air Living, Dr. Rhodes, for your time. We really appreciate it. I want to thank all of you for attending. Again, we will be emailing an evaluation form for this presentation, and also the link to this presentation so you can watch it again on our YouTube channel. So we'll go ahead and make sure that that's emailed out to you. So if you want to rewatch it, or if you maybe missed something, you can watch it again at any time. So again, I'm Julie Robb for Ida Cloverhouse Broadview and Era Living. This is going to conclude our presentation today. So thanks so much again for joining us, and we hope to see you all at future events that we're having. Stay warm.